Let's continue on then with our next chapter, which deals with internal respiration. We went through the external part. Now let's talk about internally. And this is where we end up having oxygen and carbon dioxide exchanged at the cellular level between the systemic capillaries. A lot of this is controlled by local vasculature. Those arterioles manage to control perfusion to specific areas. Sometimes it'll cause a reduction in blood flow and reduce oxygen delivery. Sometimes it'll increase it. And some organs use more than others just naturally. And this is from Malley. And you can see the various areas of blood flow on the first column there. As far as how much oxygen is utilized in the second column. And the key part there is that you want to look at the amount of oxygen that's extracted. The difference between arterial and venous oxygen contents tells you how much was pulled off. And you can see then, because of that, the PVO2 is dramatically reduced. This is why we look at a mixed venous value from the PA catheter rather than just looking at something from the right atrium. It hasn't fully mixed yet. But the big question is, where are the lungs? They're in that other part. Very limited amount of oxygen consumption by the lungs themselves. They're a very efficient organ, unlike that nasty, ugly thing called the heart. It just takes up space, uses a lot of oxygen. What a waste. We know that under normal conditions, you end up having oxygen consumed, CO2 produced. That ratio of 200 milliliters per minute of CO2 production, 250 milliliters of O2 consumption gives us that 0.8 ratio. We know that the ratio will change when you have an alteration in your substrate that you're using for feeding, specifically carbohydrates, the CHO, will increase CO2 production compared to O2 consumption to the point where the RQ is actually 1.0. And with fats, to some extent proteins, I always throw alcohol on there because, to me that's one of the food groups that we forget about a lot. They actually have a reduction in RQ. We know that we don't have enough oxygen present. We end up with anaerobic metabolism. Anaerobic metabolism, remember, with oxidative phosphorylation, you end up having a decent amount of ATP produced. You have a fraction of that when you're using the anaerobic pathway. And as an also byproduct, you end up having lactic acid produced. Is that the most sad-looking thing you've ever seen? Both. I have too. When you're looking at oxygen delivery, we have to basically take into account two different things. First of all, the adequacy. Is there sufficient oxygen present, i.e. hypoxemia? So are we delivering enough to the tissues? Is that the problem? Or is it the oxygen isn't being utilized appropriately, and is the PaO2 appropriate for the FiO2? So how efficient is the lungs at getting the oxygenation across? And this is out of the text also, and just kind of shows you the different, with normal gas exchange, both alveoli are participating. Here's an example of where I have a reduction in alveolar PO2 simply because either the barometric pressure is low or the FiO2 is less than 21%. First years today we're asking, one of them asked, we were going over the alveolar air equation. You guys remember that? They're crying and it's going on. Carry on. And one of them asked, do we ever use an FiO2 less than 21%? I said, ooh, you are good. I said, yeah, there is an instance where we do. Do you remember what it is? I didn't think so. Hypoplastic left heart? Man, we got some problems. All right, hypoventilation is a cause. CO2 is elevated. Hypoplastic left heart is where your left ventricle doesn't, because you want to maintain the PDA open. You don't want the PDA to close. So we purposely create hypoxemia. Absolute or relative shunt and diffusion defect. Those are all the more common ones that we end up seeing. All right. This gets a little bit cloudy, so stop me if I'm not making sense. Why did I not expect that to happen? But basically what we're going to talk about here is the fact that under normal conditions, a very small amount of oxygen is shunted past the lungs. We know that there's 3 anatomic shunts we primarily see: Sebacean veins, bronchial veins, and pleural veins, and they contribute a very small portion of the deoxygenated blood mixing in with the oxygenated blood. Right? You guys remember that whole situations. There are 4 other situations that involve cardiac output. Actually, 3 of them involve cardiac output, and how that change can affect the oxygenation that the patient has. So it's not necessarily something is solely wrong or solely at fault with the lungs. We end up having something where the heart becomes an issue also. So under normal conditions, and the way this is kind of showing us here is end capillary partial pressure. Does that work? Yeah. 105, because it's equilibrating with what's in the alveolus. 105. 95% of that blood that goes past there is getting that 105 PO2. On the other side, on the right side, PVO2 of 40, normal PVO2, but there's 5% of that blood. When you mix it all together, you end up with an arterial oxygen level of something around 100. Okay? Does that make sense? Okay. Now we're going to alter that. Now we're going to change things around. First of all, we're going to make it so that we have the normal amount of shunt present. If you look at the alveolus here on the right-hand side, that's basically depicting the anatomic shunts that you have. Sebacean veins, bronchial veins, pleural veins. There's 5% of the blood flow going by, and that PVO2 of 40 is mixing in. Well, what happens if I have a cardiac output that's reduced? Still my normal anatomic shunt, but now I'm hypotensive. Now I have a cardiac output that is maybe half what it should be, half of normal. What does that mean? Well, the left side still stays the same. That doesn't change. But what I have here is, because that cardiac output is low, the transit time through the capillary systemically is reduced, more is extracted. Think back to the fruit truck going through the neighborhood. If it's going through real slowly, kids come out and steal all the fruit off of it. Gets back to the home base and he's got less than you would expect. So even though we only put 5% of that lowered PVO2 in there, there's some degradation that you end up having, but it's not significant. So what I'm saying is, just reducing the cardiac output can affect the PO2, but usually it's not a significant amount. Okay, so far? All right. What happens when I have an increase in shunting? Let's say I do have this alveoli on the right-hand side filled, or able to participate, but unfortunately it's full of fluid. So it's basically non-usable, congestive heart failure. Okay. I still have now a bigger shunt because of those units being there. Normal PVO2 going past, but I end up having a reduction in arterial PO2 because of that 25% of the blood is now shunted. And this is what we see in the ICU all the time, right? Or a patient who's in the ARDS. They have a lot of alveoli that are not participating in gas exchange. Once the shunts become significant enough, yeah, I have a hypoxemia that's going to be refractory to oxygen therapy. I'm going to have to look at some other alternative means to re-expand that alveoli. So far, so good?
Why did you get that 75%?
Because 25% is shunted. So 75% has to be participating.
How did you get 25%?
I just picked it that we have a 25% shunt fraction. Just as an example. I mean, it's typically what you end up seeing in patients with ARDS. You see shunt fractions of 20, 30%. Okay. How about if I have that big shunt, say ARDS, but I also have an MI? I also have a reduction in cardiac output. Maybe I'm third spacing and I'm becoming hypotensive because all the fluid's leaking out of the vascular space and leaking into the interstitial space. Now what you end up having, again, 75% of the blood's going by good alveoli, 25% is being shunted, but now because of that reduced in cardiac output, I have a reduction in PVO2. So now that 25%, instead of having a PVO2 of 40, I have a PVO2 of 25. Notice how much more profound the drop in PaO2 is. Okay. Here it was only 60. Here it's 50. So just the fact that the cardiac output dropped made the situation worse. So it does have an effect on it. We don't normally think about cardiac output affecting oxygenation, but it can, yeah.
Explain to me again why the PVO2 is 25?
Because it's going by, because the cardiac output is reduced, it's going through the tissue slower, more is extracted. I still like my fruit truck analogy. Lastly, let's say I have a situation where I have my big shunt again, 25%, but here I have a high cardiac output. Here I have a patient who's septic, who basically is in a hyperdynamic state. Their cardiac output is 10 liters per minute. Now there's not enough time to pull oxygen off the fruit truck. Well, we're not really delivering oxygen on the fruit truck. Pulling fruit off the fruit truck.
Or oxygen off the oxygen.
Or oxygen off the oxygen truck. That's a good one. So we end up having a situation where the PVO2 is elevated. The fact that I have a 25% shunt at a PVO2 of 50, well, it's better than the previous one, but it's still hypoxemia that I'm dumping in there. The problem is the shunt that we need to re-expand again. Cardiac output just contributes to the worsening of it. So what? Well, don't always assume that improvement or deterioration in PaO2 is solely because of pulmonary gas exchange. Especially when you see an abrupt change that I can't think of any reason why all of a sudden I should have that much of a drop in my saturation. Suspect maybe a change in cardiac output that is there. And there are other things, obviously, that can change the PVO2 even in the face of a normal cardiac output. Things like fevers, things like sepsis. They can alter where the blood flow is going. They may increase blood flow to the organs that are extracting more, and you end up having a worsening of the PVO2. Now, you don't have this slide. It's because it's in your book, but nobody buys the book, so who cares? But this is one of these on-call cases that he has, and in case you read it, let me go ahead and read it to you. It says, shortly before 11 a.m., acute chest pain, shortness of breath, frequent arrhythmias, and hypotension develop in a 52-year-old female with severe pneumonia. I want you to interpret the blood gases and patient's condition at 11 a.m. So we're going to look at the first one there, the 10 a.m. gas. Saturation's 93%, 737, 37, and 72 PO2, 25 bicarb, and a FiO2 of 50%. What do you think about those gases? They're okay, but she's got on 50%, she still only has not even a normal PO2, a tolerable saturation. Okay, so she's got some work to be done to get back to normal. Okay, 11 a.m. Now her saturation has dropped to 84%. Her pH has fallen to 7.28. Her PCO2 has fallen to 29. PO2 to 49. Bicarb to 13. FiO2 to 50%. Okay. So I want you to list abnormal data and noteworthy information and classify it. So how would we classify the second blood gas at 11 a.m.? Thank you. I was getting worried there for a second. With Moderate hypoxemia. What do you think happened? You think her pneumonia worsened all of a sudden? What's causing the arrhythmias? What's causing the hypotension? The pneumonia? The low PO2? What other interventions would you want to do? Well, what value is missing from here? Heart rate and blood pressure, right? We know she's hypotensive, so let me just say it's 70 palpable is her blood pressure. She's diaphoretic. She's throwing PVCs. She's dyspneic. She needs more oxygen, okay. What else does she need? What else do we need to evaluate is her heart. This is the example of where all of a sudden, cardiac-wise, just the fact that her cardiac output worsened, now she's coming back with a PVO2 that's lower, and she's got a pneumonia, so we know she's got some shunt. That's what's causing the hypoxemia. So we got to not only address the oxygenation and possibly looking at maybe some BiPAP or something, but we also got to assess cardiac output. And how do I assess cardiac output? How do I measure cardiac output? How do I measure cardiac output, though? Put a PA catheter in and do a thermodilution cardiac output. Okay. Has anybody seen a cardiac output done? Okay, then. We'll leave it at that. But yeah, we want to be able to evaluate. Is the preload low? Is the afterload high? Is the contractility poor? Being that she's, how old was she? 52? 52 with pneumonia, did she maybe have an infarct? Get a 12 lead. Okay. All right. Enough of that. We'll stop there.